The era we are living now, it's a completely different era from what we have lived during the last 15 years. We should expect overall response rates in the range of 70, even 80% in the relapsed refractory setting, perhaps CR rates in the range of 20, 30%, and this really establishes or paves the way for postulating a deep response, including MRD negativity, as a potential goal of therapy for fit relapsed refractory patients. We believe that patients with high-risk disease, either it is cytogenetically defined upfront, either it's because it's a relapsed refractory disease, altogether, high-risk patients are those that benefit the most from reaching deep responses, particularly MRD negativity. This should be a goal of therapy for those patients in which this may be feasible. On the other hand, we need to understand and develop the biomarkers to identify patients that, despite they continue to present residual disease, may still experience a more chronic myeloma. In other words, not so much of a true and a deep response, but nevertheless a prolonged progression-free survival. I believe that with some novel therapies, for example, immunotherapy, this might be feasible for a significant fraction of patients, and we also should work on how to identify such patients prospectively. Third area, to understand the biology of ultra-chemo-resistant MRD cells. The key to understand chemo-resistance to state-of-the-art myeloma therapy, we believe, will go through the in-depth study of the biology of MRD cells.